Hello members and guests of ICS. Thank you for allowing us to present our data. My name is Rahul Patel and I'm a fourth year medical student interested in urology. I worked on this project with Dr. Zimmern, who's been involved in mesh complications for a long time now. I was intrigued by his office-based vaginoscopy procedure and decided to review its role in his practice. No disclosures. There was a recent statement last year by the American and International Urogynecological Societies on the management of mesh-related complications such as pain or exposure, and it highlighted multiple gaps in management due to the lack of standardized data and inconsistent terminology used to classify these complications. Vaginal mesh exposure is defined as a visualization of mesh through the vaginal epithelium. The incidence ranges depending on the type of material used, but it does seem to increase over time, as noted by Nygaard and colleagues. It may be asymptomatic or present with vaginal bleeding, discharge pain, and partner discomfort. Examination is often limited due to intolerable pain, distorted anatomy such as a narrow vagina, or subtle findings that may go unnoticed, often requiring examination under anesthesia. Vaginoscopy is an office-based examination of the vaginal compartments with a flexible scope that Dr. Zimmern uses in these situations without the need for anesthesia. However, there's a paucity of data on the use of vaginoscopy in general and none on its use in mesh-related complications. Therefore, the objective of our study was to evaluate the yield of vaginoscopy in detecting vaginal mesh and suture exposures, as well as determine how these findings influenced management. For that, we performed an IRB-approved retrospective review from 2014 to 2020 of all office-based vaginoscopies done at our center. We collected baseline demographics, presenting symptoms, and indications for vaginoscopy. We reviewed the findings for type and location of any exposures, as well as the initial date of placement based on the prior op notes when available. We also reviewed other imaging done at the time, the planned surgical approach, and the intra-op note in order to corroborate our findings. We excluded incompletes, duplicates, and those without op notes. We grouped vaginoscopy indications into 1 of 4. Those with any vaginal symptoms with any history of mesh, those with a history of prior removal attempts at other institutions, those with exposed bladder mesh to exclude concurrent vaginal exposure, and those who had vaginal mesh removal at our institution in order to verify no recurrence. As mentioned, a flexible irrigation scope is used to sequentially evaluate the vaginal compartments and document any findings. It's performed in less than 1 to 2 minutes, and here are some example findings. On the left, this is a clear fiber of left apical prolapse mesh that was overlooked on finger and speculum examination, causing recurrent vaginitis and bleeding. On the right is an exposed mesh sling with stones on the left lateral fornix in a patient refusing vaginal examination due to pain. A total of 138 women met our study criteria with 159 vaginoscopies done. Most of these were in their 5th to 6th decade of life, Caucasian, status post-hysterectomy, postmenopausal, and non-smokers. The most common indication was vaginal symptoms without any prior attempts at removal. Symptoms included dyspareunia, bleeding, discharge, with many having more than one. The median time from placement of mesh to detection was 7.5 years. The total yield of detected mesh and sutures for all indications was 32%. Of note, there were no detected exposures in the exposed bladder mesh group. Here's a flowchart characterizing our findings, imaging, and approach to management. Of the 51 patients with detected exposures, 28 had prolapse mesh, 11 with anterior-posterior, and 19 with apical. 12 had mid-urethral slings, therefore all in the anterior compartment. 3 had both sling and prolapse mesh identified, and 8 had sutures located in the apex. Translabial ultrasound, as shown on the left, was performed in half the cases and suspected only 3 sling exposures. MRI was performed in half of the cases as well and detected no exposures. As depicted in the bottom right image, it fails to differentiate the hypointense tissue from scar tissue versus inflammation versus exposure. In that same patient, vaginoscopy confirmed exposure at the posterior vaginal wall. The majority of exposed sutures were at the bone. The majority of exposed slings were obturator, and about 1/4 of the identified mesh was gyn-care-free mesh. Most importantly, the most common location of exposure was at the apex. The most common approach to removal was vaginal at 90%, and 93% of intraoperative findings corroborated with vaginoscopy findings. There were only 3 that had an additional exposure found and removed during the operation. Strengths of our study was that it was performed by a single experienced FPMRS physician with well-documented findings, as well as our surgical approach to exposure, which allowed for confirmation of our findings. Limitations: this is a single study center, so it limits generalizability, and the lack of consistent surgical management of non-exposures prevented us from predicting the negative predictive value of vaginoscopy. In conclusion, office-based vaginoscopy is a safe and simple tool to exclude, detect, or confirm mesh or suture exposure in selected women. It's especially useful in those with vaginal symptoms such as pain, narrow vagina, or difficult exam, or in those who had prior mesh removal attempt, especially at the apex. It has a higher yield of detection than imaging studies with a greater than 90% accuracy. And by locating the site, nature, extent of the exposure, vaginoscopy aids in surgical planning of mesh-related complications. Thank you for your time.